Good morning, ladies and gentlemen, respected chairs. At the outset, thank you so much, Samir. I think it's my 5th year for Breathe here, and it's always a privilege to come here to Nagpur and be in front of this audience. I've always loved coming here and always enjoyed my talks whenever I'm here. Uh, it's very hard to come after an interventional talk, especially from that of my good friend Bala, when he's made it so exciting. Mine may sound a little more sleepier than what he has really spoken about. So I'll try my best to keep you guys awake, but let's see what I can do. So I'm going to be talking today on malignant pleural effusion. Before I head ahead, I used to work for Narayana Vidyalaya for many years, and now I've moved to a new hospital called Spash. I bring greetings to you from here. And today what we're going to be discussing is I'll basically introduce the topic. We'll briefly run through pleural physiology. I'll talk about malignant effusions, but I'll also talk a little bit about what a paramalignant effusion is, which is not something which is usually discussed. We'll talk about the evaluation, and while the evaluation is happening, I'll move in with a little bit of myths and pearls about the pleural fluid and things like that. We'll talk about the management of malignant pleural effusions, and I'll reflect a little bit on the latest BTS guidelines and also the ATS guidelines. We all know that indwelling pleural catheters are here to stay, and it's been over 20 years that they've been here, and we'll review the evidence on the indwelling pleural catheters, and I'll end my talk with a few take-home points. So what basically is pleural effusion? So I'm going from really the hardcore basics. It's basically abnormal accumulation of fluid within the pleural cavity, and of course there is imbalance between the formation and absorption, and there are local and systemic causes which cause effusions. We all know all of this, that there is increased formation or there is a decreased absorption, because of which pleural fluid accumulates in the pleural space, and these are the various areas from where the formation happens. So the formation of pleural fluid is from the parietal pleura, the interstitium and the peritoneum, through which it comes there, while the absorption happens in the lymphatics. But remember, the most important point is our pleural fluid lymphatics have the ability to absorb 20 times that of production. Right. So what it basically tells us is it has to be an overwhelming cause of fluid formation that will lead to decreased absorption, and therefore the fluid accumulates. So that's something to keep in mind. And of course, there is something called the hydrostatic pressure and the oncotic pressure, and the pleural fluid formation and absorption is a balance of these forces, which is to and fro, and the pressure gradients basically help to maintain this particular formation and absorption. And of course, there are various mechanisms in different diseases that have been proposed for the formation of, pleural fluid. I won't go into the details of it. For those of you taking photos in the audience, please feel free to write a mail. I'm happy to send you all the slides. You can read it. These are all teaching training slides. My email is kedarhibare@gmail.com. I'll put it up again. So just write a mail to me. Just listen to me, because I'm introducing many important concepts. Right. So as far as the examination goes, mediastinal shift to the opposite side when there's moderate to massive effusion is a clinical finding. There's decreased VF. When you percuss the patient, you have stony dull percussion note, and of course there are decreased or absent breath sounds. And then the evaluation of pleural fluid, the first thing you always do is you want to classify them into either exudates or transudates. So this is pretty simple so far. So what we do then is we list out the common causes of transudates and exudates and so on and so forth, and then we say, okay, it's probably this, it's probably that, and we remember with a lot of reverence Mr. Richard Light, who actually gave us the Light's criteria to differentiate between the transudates and the exudates. And of course, if you go through textbooks, you will really find a lot of these kind of complicated algorithms which will tell you how to go about evaluating the effusion. So you start out with a few set of investigations, and over a period of time you say, okay, these are not enough, I need more investigations and more investigations. So this is just one of those algorithms. And then when you have an undiagnosed pleural effusion, which means your initial analysis is not pointing to a particular cause, then you go further and then get more advanced investigation, and a complicated algorithm would look something like this to you. But the absolute truth that is important for us to understand is that the assumption is that our diagnostic algorithms are going to 100% tell us whether it's an exudate or transudate. It's not often the case. Clinical judgment is superior is what something we assume. And we all think that a patient has only one illness with no confounding factors. But the reality is far from all of this. And the definite and this defines the role of advanced investigations in pleural fluid diagnostics. A complicated algorithm will involve something like this. It's very hard and mind boggling to even imagine what an undiagnosed pleural effusion can lead our working diagnosis into. So do not be fooled by it. In fact, even the most experienced ones sometimes can fumble into their diagnosis. I'm not trying to make it difficult. All I'm trying to show you is that an algorithm for pleural effusion, undiagnosed pleural effusion, can get complicated and you need more and more investigations. Now let's come back from all of this general introduction to the topic for today, which is malignant pleural effusions. And what does malignant pleural effusion basically mean? That either your pleural fluid cytology or your pleural fluid biopsy is positive. It's as simple as that, right? So you do a cell cytology and it comes positive. That's a malignant pleural effusion. And how does this happen? It's because either there's a hematogenous or a lymphatic spread from primary cancer, or there is a direct pleural invasion, or you may have a malignancy which is a primary mesothelioma from the mesothelial cells from the pleura. So these are basically how the malignant cells enter the pleural space. And what does it tell you? That it signifies an advanced cancer and the prognosis is poor. You're going to lose the patient anywhere between 3 to 12 months, which is the prognostication that we really want to tell the patient about. But let me also tell you, with the advent of newer molecules and immunotherapy, this has become a little more prolonged now, and we're getting better and better at managing this prognosis, poor prognosis of 3 to 12 months for malignant pleural effusions. Remember that about 15% of all patients with cancers are likely to develop these effusions, and lung and breast CAs are the most common, where you will see about 50 to 65% them developing this. And our goal as interventional pulmonologists and pulmonologists is that we give the patient symptom control, because breathlessness is the most common symptom of effusion. We want to improve their quality of life in their last days. We want an acceptable minimal intervention to give this particular relief. And in the Indian settings, we are all very worried about affordability, cost, and etc. And of course, our preference has to be for lesser invasive procedures rather than more invasive procedures. A word about paramalignant effusions. We all think all effusions, if there is a malignancy anywhere in the body and you see an effusion, we automatically assume that it is a malignant effusion. But remember that it can be a paramalignant effusion as well. And what does that mean? It basically means that this effusion is because of the is occurring because of the tumor effect, and it is an indirect mechanism. And why this happens is either there is a bronchial obstruction causing the effusion, or a mediastinal lymph node infiltration, a thromboembolism, or a superior vena cava obstruction. So any one of these can also cause. Apart from that, there are many other causes. Remember things like a person may be nutritionally depleted in cancer, okay, and that itself may cause hypoalbuminemia and can cause effusion as well. So there are multiple mechanisms. I'll come to it a little later in the next slide. So what is important to understand is here the fluid cytology and the pleural biopsy, if you do any, are negative. So in a malignant effusion they are positive, here it is negative. And of course these effusions do not portend a very poor prognosis in malignancy. So that's something again to keep in mind. And they are basically managed according to the underlying etiology. So if there's an embolism, of course you will invoke the embolism algorithm and then put the patient on anticoagulation, etc. So what are these causes of paramalignant effusion? That itself is a huge list, and that can happen, like I said, because of the local effects of tumors or the systemic effects of tumors. They can be the complications of therapy, which may be radiation early or late. And of course, chemotherapy itself can also induce pleural effusion. So all of these can be paramalignant effusion. So do not automatically assume that every effusion in a malignant case is a malignant pleural effusion. That's basically the message. So how do patients present with? Most of them present with breathing difficulty, dyspnea, sometimes grade 2 or grade 3. They have associated chest discomfort, and of course they also tend to complain of cough, weight loss, loss of appetite, easy fatigability, and generalized weakness. But remember, the challenge is to confirm that the breathing difficulty is because of the effusion. It's not always so, and there could be an underlying lung disease which is causing the breathing difficulty, and you may assume that the breathing difficulty is because of the malignant pleural effusion, which is not necessary. So malignant pleural effusions also do not cause a significant amount of hypoxia. So if you have a patient and he has got hypoxia, please ensure that you remember your hypoxia algorithm, where you go back and look at VQ mismatches and shunts, and these do not happen in malignant pleural effusions, and the cause can be something else. So think that if there is a patient with hypoxia and an effusion, and you know that this patient has a background malignancy or there's a positive malignant pleural effusion, you may have a concomitant pneumonia, an endobronchial obstruction, or a pulmonary embolism as well. So let's go to the malignant pleural effusion per se. So now I'm going to getting a little bit into the realm of the latest guidelines and how they tell you to manage effusions. So today we are talking about malignant pleural effusions are either being symptomatic or asymptomatic. So if they are asymptomatic, which happens in about 10 to 15% of the patients, at presentation, important to remember that if a patient is asymptomatic, it does not necessarily mean that you intervene at all. All that you require to do is continue to treat the tumor, and palliate the patient according from the, medical oncology point of view. Do the first thoracentesis, confirm that it is malignant pleural effusion, and that's really about it. Do not do anything further for it. But remember that a malignant pleural effusion over the course of the malignancy is likely to turn symptomatic, and an anti-tumor therapy which the medical oncologist is likely to give, it may help in its resolution, especially in breast, ovarian, prostate cancers, etc. But what if the effusion is symptomatic? Remember also, do not correlate the size of the effusion. You may have a small effusion, but you may have the patient much more breathless than that. So these sizes of the effusion do not correlate with the symptoms of the patient. Also remember that there is a high possibility that the patient can have a non-expandable lung. So you tend to tap the fluid and then, or you put in an ICD and then you find that the lung is not expanding. You're stuck at that point in time. And basically this is a problem that you're likely to see. So the non-expandable lung was the new terminology which the British Thoracic Guidelines introduced, and this basically means that despite tapping the fluid, your lung is not likely to expand completely. And again, of course, symptomatic effusions tend to recur, and it all depends upon the underlying cause of the tumor, the ability to tolerate various interventions, and of course the patient's wishes. So let me summarize this aspect. So when you have a malignant pleural effusion, it may be asymptomatic, a symptomatic malignant pleural effusion with a non-expandable lung, and it again may be a symptomatic malignant pleural effusion with an expandable lung. So these are basically what the guidelines are going to tell you. But every effusion that you're likely to see is not going to be as straightforward as asymptomatic and symptomatic. So there may be some other problems, and especially septated and loculated malignant pleural effusions are something that are being discussed in the British Thoracic Society guideline. The treatment for this has to be individualized. What the guidelines suggest in septated is that you do thoracoscopy, IPC with fibrinolytics, or you will have to individualize the treatment depending upon the septations. If it is loculated, there's always a preference for IPCs. Fibrinolytics or a surgical referral may also help. So these are some things that we have to bear in mind during the management of these special situations. Now, how do you diagnose? Of course, one of the most easiest investigations we always have at hand is X-rays. Often it is 80% large. In about 10% you have 500 ml of fluid, and in 10% it's massive. So remember that if you have an X-ray with this kind of, sort of a thing, when do you suspect it? When there is an underlying lobar or a lung collapse, if the mediastinum is fixed, or there is loculation. These are just various X-rays where you will also be seeing some, lung infiltrates which tell you that pleural thickening, which will also pleural thickening or nodularity, which indicate that the underlying cause of the effusion malignancy. But X-rays have been there for many decades now, but the new kid on the block is thoracic ultrasound. Today in pleural physiology and pleural disease management, the ultrasound of the lung has come into the center stage, and everything that we discuss around pleura and pleural physiology and pleural management or pleural disease management cannot do without a thoracic ultrasound. So there's a lot of emphasis today on how much ultrasound is part of our curriculum in the pleural diseases, and of course we all know that it is very sensitive, better than chest X-rays. If you find on ultrasound that there's a pleural thickening of more than 1 centimeter, you notice pleural nodularity, or there is a diaphragm thickening more than 7 centimeters, these all indicate malignancy with a specificity of 96%. So if you are going to get better at ultrasound, the one thing that you really, if you ask me what is my take home message, learn pleural ultrasound for better management of pleural diseases. That's really what I'm going to tell you. And of course there was a systematic review and meta-analysis on this particular aspect about the role of thoracic ultrasound, which is very, very strongly established. So you basically look for nodules, you look for collapsed lung, you look for diaphragmatic nodules to tell you more and more about what is the underlying cause in such situations. And of course these findings not just correlate with X-ray, but you go ahead and do your CT scans. The very same findings that you find in the ultrasound can also be seen in CT scan. So basically it tells you how important ultrasound is. And of course, ultrasound has not just remained a tool for the common man. Many cardiologists are now using it. With the advanced features in ultrasound and advanced techniques, you are able to do many more things than the routine picking up of pleural effusions to just say that we are malignant or not. So this was a very interesting paper published in Chest which spoke about picking up ultrasound, picking up a non-expandable lung by doing ultrasound of the chest. And they basically looked at something called as the strain and displacement, and they categorized three categories where they were able to predict, the possibility of a malignant effusion just by doing ultrasound with a very, very high sensitivity and specificity. Coming to thoracentesis, which is something which is very central to how we go about it. Malignant pleural effusions, as we all know, are generally exudative, but remember they can also be transudative in 5 to 10% of the cases where the concomitant cause need not be malignancy. You need about 50 to 75 ml for a diagnosis and also for molecular testing, which is now central to malignancy management. And of course, with increased number of samples that you send, you are likely to be able to get better and better at the management or rather picking up the malignant cells. So a few myths and pearls. Fluid differential provides clue to the origin. Remember that if you have lymphocytic pleural effusion, we always tend to think TB is our first diagnosis in an endemic country like India. But also remember malignancy is a possibility. You have eosinophilic pleural effusion. Again, one of the differentials for a eosinophilic pleural effusion is malignancy. The most malignancy is the most common cause of bloody effusions is what we all think. So whenever we see bloody effusion, our first thought process is to run and say this is likely malignant. But remember, it's only 11% of malignant effusions are bloody. 40% of bloody effusions were malignant when they were for other causes like trauma, pneumonia, post-cardiac injury syndrome and embolism. A negative pleural fluid cytology does not rule out malignancy. We always think that if it's negative, there is no malignancy. It's not necessary. It again depends on the tumor type. And on the x-axis in this particular picture, you see the sensitivity of pleural fluid cytology to the various underlying causes of malignancy. So if you have something like an ovarian, lung, breast or gastrointestinal malignancies, your ability to pick up malignant cells on the pleural fluid is high. But if you have something like a sarcoma, you may not be able to get pleural malignancy despite it being positive on the pleural fluid cytology after doing it multiple times. The cytological diagnosis of malignant pleural effusion requires large volume. This is something that we tend to be taught as residents, that all the fluid that we drain should be sent for analysis. It's not necessary. All that you require is 50 ml of fluid, but up to 50 ml of fluid incrementally can give you a better yield, and more than 50 ml didn't change the diagnostic yield in malignant pleural effusion. The other problem we constantly encounter in India is the possibility of TB, concomitant TB and the high ADA. So there are newer and newer studies which are happening, which is looking at the ADA between 40 and 70 for us to be able to pick up. Of course, this is just one study, but I think we require more. And what they are now suggesting is to look at the pleural fluid CA levels and the nodularity on the ultrasound to be able to predict effusions. I think this was one of your quiz questions for the teams here who are sitting, the Abrams pleural needle biopsy. I think very few people in this room except the seniors on the first and some of the faculty may have seen an Abrams needle. More and more you will get to see those automated lung shooting kind of needles which are used by interventional radiology. And of course, this is just another photograph where you're doing an image guided biopsy. Blind pleural biopsy, to the best of my knowledge, I don't think there's any center which is doing it at all. So the next part is about non-diagnostic biopsy. What happens next? You tend to do a chest CT and of course you try to do a PET scan. But what is reported, and they've studied this in the literature, is a PET may not be very helpful. So if your suspicion of the malignancy is higher, repeat the pleural biopsy in such situations rather than going in for a PET scan. Of course, thoracoscopy comes in as the next most important modality. And of course, when you do thoracoscopy, also ensure that you do, and if you confirm or the lesions look like malignancy, or you are able to do an intra-op visual analysis or a histopathological analysis of the cells, and you're able to pick it up as malignancy, you can come out with having done the talc pleurodesis in the same setting. From the academic point of view, these two scores are extremely important, the Lent score and the PROMIS score. I won't go too much into the details. So you will see that there are two slides or two, halves of the slide which will tell you what the Lent score is and what the PROMIS score is. And they basically will help you prognosticate the patient, which is bad. But in the era of immunotherapy, I think it's very, very important that we prognosticate them better. While another important point is that the recent guidelines don't talk a lot about manometry, but if and when you do it, an elastance of more than 14.5 centimeters of water per liter is the number that you really require to remember. Okay, especially when you suspect a non-expandable lung. From a management point of view, you have 4 or 5 interventions that you can do. One is thoracentesis, talc pleurodesis, indwelling pleural catheters, or a combination of that. And do not withhold chemotherapy in malignant pleural effusions. Let the background problem be handled by your medical oncologist while you manage the respiratory symptoms. So this is the algorithm from the ERS, where you have a symptomatic malignant pleural effusion. The first step is thoracentesis. If it improves breathlessness, that's great. So look for re-expansion on the chest X-ray. If there is an expansion, look for the Lent score. Make the decision jointly with the patient whether you want to go ahead with torcoscopy or IPC, or only an IPC placement, and that's basically your algorithm. Briefly, I'm going to be talking about indwelling pleural catheters. These are the IPC trials. We've been having IPC from almost 2006, and these are the various trials. I am just summarizing everything in just one particular slide here. Every single trial on indwelling pleural catheters is here. How it started out is IPC is a viable outpatient alternative. Over a period of time, the trials did show that IPC offers effective symptom control. Then came the era where we were debating whether you should do an alternate drainage, only symptomatic drainage, or a routine daily drainage. And then we came to the point where we said routine daily drainage is possible and is much better for patients. Daily IPC drainage got established with the ASAP and the AMPLE-2 trials. Of course, we wanted to get better at managing the complications of IPC in terms of the infection. So silver nitrate coated IPCs came in, but that failed. And of course, now we are really investigating the use of talc administration via IPC and whether that's going to help. So this is basically the summarization of every trial on IPC. Again, I'm not going to go into this complicated thing. This is just, again, management of pleural effusion with use of an IPC. And just a couple of photographs. What is important for you to remember is you need to tunnel the catheter about 5 centimeters under the dermis to be able to, and this basically prevents the infection. So these are just photographs showing the insertion. All of you can go to either the Rocket Medical's website or the BD's website, where this entire technique is uploaded as a video. So what the guidelines talk about intervention, timing with biopsy, that you do talc pudraj if you do torcoscopy, and of course adverse events are very, very minimal. 8% infection risk, and do not remove the IPC if there is an infection. Treat the patient with antibiotics, because many people, the moment you have infection, they tend to take the IPC off. So I'm just going to leave you with a few take-home points that malignant pleural effusion signal advanced cancer. The focus should be on symptom control and improvement in the quality of life. They are the first line options. The IPCs are the first line options in non-expandable lungs. Important to always remember, you control symptoms. Daily drainage is something that you insist on. And if the patient has very, very poor quality of life, just do therapeutic thoracentesis, and a shared decision making with patients is something that is likely to help you. And an early referral to a center which manages pleural interventions is always going to be better. Thank you, ladies and gentlemen, for the patient hearing. I hope I have been able to make this topic a little simpler for you.